Jasmine. Today we are going to study about one of the interesting joint in our body, that is the shoulder joint. So today we are going to study about the shoulder joint. So shoulder joint, it is also known as glenohumeral joint. So this attaches your upper limb with the axial skeleton, and we know all the axial skeleton is formed by the bones of the central body, that is the bones that forms the head and neck or the skull region and the vertebral column. So the glenohumeral joint or the shoulder joint, this connects or this attaches your upper limb with the axial skeleton. So it is one of the most mobile joint in our body, and always the mobility is inversely proportional to the stability. More the mobile joint, the stability will be less. So that's why I have told that it is inversely proportional. Mobility and stability, they are inversely proportional to each other. So shoulder joint being one of the most mobile joint in our body, so it is less stable. Less stable in the sense there are more chances of dislocations or subluxation. So dislocations, they are usually accompanied by the fractures of the bones which are involved in the shoulder complex. So this is, I am having this articulated shoulder joint. You can see the two components of the joints here. The two components are formed by the two important bones. That this one we have already studied in our osteology classes about everything about the scapula as well as the humerus. So you can see this is we have articulated to show only this region, the shoulder joint region. So I have told that this is one of the most mobile joint in our body. Why it is one of the most mobile joint? Because it moves in more than two direction. So we say it as multi-axial movement. And I have told the other name for the shoulder joint, that is a glenohumeral joint. Glenohumeral joint, I will say you why it is called as a glenohumeral joint, and it has a 3 degrees of movement. 3 degrees of movement means it will move, it shows several movements like flexion, extension, abduction, adduction, medial and lateral rotation, and combination of all these we say it as a circumduction. So these movements, they are occurring at the 3 degrees, means one in a vertical axis, one in a horizontal axis, and another one in a anteroposterior axis. So we will see this joint, shoulder joint, by one headings. So first I have told you that think this joint is of definitely of which region, that is the upper limb region, and the type of joint. So definitely this is a synovial joint, means it is a freely movable joint. So now we have to think synovial joint, it is freely movable, it is moving in more than two direction, that is a multi-axial movement. So it comes under which variety? It comes under the ball and socket type of variety. So here the ball is represented by the head of the humerus and the socket is represented by the glenoid cavity of the scapula. Now you understand why it is also known as a glenohumeral joint, because this joint forms the articulation between the glenoid cavity of the scapula and the head of the humerus. So that's why it is known as a glenohumeral joint. So coming to the next part of the joint, that is the articulating surfaces. So for any sort of joint, articulating surfaces, we will see which is the proximal articulating surface and which is the distal articulating surface. So here the proximal articulating surface is the glenoid fossa or the glenoid cavity of scapula, and the distal articulating surface is the head of the humerus. So you know the head of the humerus that comes under the upper end of the humerus, not whole of the upper end of the humerus contribute in the shoulder joint, only the head of the humerus forms the shoulder joint. Then we will see in detail about this articulating surfaces. So this is the glenoid fossa, or you can say the glenoid cavity. So this whole glenoid cavity is covered by a articular cartilage, that is a hyaline articular cartilage, which is thin in the center and thick at the periphery. So again one fibrocartilaginous rim is there that surrounds the periphery of this glenoid cavity. So that fibrocartilaginous rim is known as glenoidal labrum. So if you have you seen the onion slice, when you cut the onion in a circle wise, so that slice how it looks exactly, if you want to remove that glenoid labrum, it will look like this. Now why this, what is the function of this glenoidal labrum? So this glenoidal labrum, this deepens this glenoidal fossa so that the head of the humerus can accommodate it properly. Not whole of the head of the humerus is accommodating, only 1/3 of the head of the humerus is accommodating in this glenoidal fossa. So this is about the proximal articulating surface. So this glenoid fossa is the socket component of the ball and socket type of joint. Now coming to the distal articulating surface, distal articulating surface is represented by the head of the humerus. You have seen the ball. So this represents the ball component of the head of the humerus. So this is the head of the humerus which articulates with the glenoidal fossa. Now, when we talk about the directions of this glenoidal fossa and the head of the humerus, head of humerus is directed backwards, upwards and medially, whereas glenoid cavity is directed laterally, upwards and forwards. So, this is the direction for both the articulating surfaces. Now, we will see about the ligaments of the shoulder joint. So, remember, for any sort of joint, two things are always common, that is the fibrous capsule or the capsular ligament, and one on the inner surface of the capsular ligament, one membrane is there that is known as the synovial membrane. So, these two things, that is the capsular ligament and the synovial membrane, are present in every joint, only the attachments will differ. So, in shoulder joint, what are the different ligaments we are going to see? So, capsular ligament or the fibrous capsule, then the synovial membrane, glenohumeral ligaments, coracohumeral ligaments and the transverse humeral ligaments. So, we will discuss it one by one. First is the capsular ligament of the shoulder joint. So, actually this is the capsular ligament. This is a loose envelope that completely surrounds the shoulder joint, and this permits the free movements. Understood? So, capsular ligament, this is a loose envelope which permits the free movements. Now, what are the attachments? Again, attachments we will describe it like how this capsule is attached medially. So, here medial part will be the scapular part, glenoid fossa of the scapula, and the lateral part will be the head of the humerus. So, medially this capsular ligament is attached to the peripheral margin of the glenoid cavity, but outside the glenoidal labrum. I have told you what is glenoidal labrum. It includes the long head of biceps brachii. We know that long head of biceps brachii is coming from this supraglenoid tubercle, but excluding this infraglenoid tubercle. So, this is the medial attachment of the capsular ligament. Then what will be the lateral attachment of the capsular ligament? So, it is attached around the anatomical neck of the humerus. We all know that anatomical neck of humerus is the neck that completely encircles the head of the humerus. So, this is the anatomical neck. Don't confuse it with the surgical neck of the humerus, which is the constricted part between the head or the upper end and the shaft. So, this is the surgical neck and the anatomical neck. Now, we are saying about the capsular ligament attachments laterally. So, this capsular ligament lateral attachments, it attaches to this anatomical neck of the humerus, but this is deficient at 2 points. One, we know that this is the intertubercular sulcus. So, capsular ligament is not present here. I will say you the reason why it is deficient at the upper part of the intertubercular sulcus, and inferomedially it extends 1 centimeter below to encroach on the surgical neck of the humerus. So, these are the attachments for the capsular ligament. I have told you the medial attachment and the lateral attachment. So, why this is deficient on the upper part of the intertubercular sulcus? Because from here the long head of the long tendon of the biceps brachii passes. That is why here the capsule is deficient. Now, this fibrous capsule is supported by the expansions of the foreline tendons. From the front, the tendons are subscapularis. We know the subscapularis is present in this subscapular fossa. So, this fibrous capsule, it needs some support. So, from front or from the anterior aspect, who gives the support to this fibrous capsule? So, this is the muscle, that is the subscapularis muscle from the front. From the above, supraspinatus. So, this is the supraspinous fossa. So, from the above, supraspinatus, from the behind, infraspinatus and the teres minor, and this subserves the functions of dynamic ligaments. Lower part, when you see the capsule or the shoulder joint is covered by all the sides, like from the anterior, it has a support from anterior, from superior, even from the posterior. But what about the inferior part? It is least supported, or even we can say there is not much support by any muscle from the inferior aspect of the shoulder joint or even for the capsular ligament. So, the dislocations are more common in the inferior region, and that can lead to the injury to the axillary nerve and even to the posterior circumflex humeral vessels. So, these are the supports for the capsular ligament. This is the slide to show the rotator cuff muscles. So, this is the front view and this is the posterior view. From the front view, you can see the muscle subscapularis and supraspinatus. This supports the fibrous capsule from the anterior and superior aspect, and from the back side, you can see the infraspinatus and the teres minor muscle. So, this white color part you are going to see over here is the tendons of these muscles. This gives the support to the joint from the posterior side.